Good morning, everyone. So far we already discussed the basics of POCUS, then about the vexus and basics of transplant Doppler. So now we are going into the clinical real scenarios. So I'm going to discuss few interesting cases where POCUS helped me to manage the patients and difficult scenarios. So POCUS, again, we discussed that we are not going to replace, it's just a limited ultrasound examination to answer the focused clinical questions, like whether there is hydronephrosis, is there any collection near the graft, or is there any lymphocyte or urinoma is there or not? Is there significant post-void urine or not? Is there adequate graft perfusion? As Dr. very well explained, how we can just see the grayscale of the kidney and see the perfusion and Doppler indexes, and we can be assured that this graft is very good and we are nothing to worry. So what is the RI, what is PI, and what is the pattern? That we'll discuss today. So this is not definitely an alternative of radiologist or cardiologist performed examination. This is just a focused examination to give additional information. This is just extension of examination or a fifth dimension of examination. So this part is almost covered. This is how normal external iliac artery anastomosis in right iliac fossa graft looks like. And generally we do the scan baseline in first 24 hours. In my setup, I do at same day evening, we do transplant in the early morning, and same day evening we do a baseline scan, transplant kidney Doppler, to know the indices, is there any collection or not, and how the anastomosis is. And we repeat as and when required. So generally before discharge, I do at least 2 or 3 transplant Dopplers. And these are the routine parameters we see in a transplant kidney. So generally the size should be normal. Then we compare the echogenicity, we see for the CM differentiation, we see for any collections, and we see for the indices and Doppler patterns. So whenever we compare, we're learning the basics, this part is also very covered. But this light gray area outside is actually is a liver echogenicity, and we are comparing. So if more whiter, like airborne diaphragm, stone, or renal sinus, then it is a hyperechoic. So the structures which are more brighter or more whitish are hyperechoic. Which are equal, these are like liver and kidney are isoechoic. So if kidney is more whiter, then we can say it's a hyperechoic or increased echogenicity, the radiologist right. And if it is more darker, like it happens in the graft kidney pyelonephritis, the cortex become more hypoechoic. So generally we compare with the liver. And the fluids, particularly the clear fluid like urine and lymph, they usually are very dark or anechoic. So this is a normal graft or a kidney, how it looks. So this is a cortex, these are the medulla, this is adequate CM differentiation. This is renal sinus fat, which is generally slightly hyperechoic. And we look for pelvis here, and if there is hydronephrosis or a fullness, we can see there. So this is how we compare in the native kidney. So because the right kidney is below the liver, so we compare with liver. So this is almost isoechoic, so this is normal echogenicity. And here, as compared to spleen, kidney is generally slightly hypoechoic. So this is how right iliac fossa and left iliac fossa. So transplant kidney lies above the external iliac and internal iliac arteries. These are external iliac and internal iliac. External iliac artery and vein. Regarding color Doppler, all parts are very well covered by the Dr. Well. So without wasting much time, I will go to the clinical cases. This is how a very good graft will look on a Doppler. This is a normal pattern which is assuring to all of us, and this is a sharp systole. The peak systolic velocity is here, and then there will be slow decline, and there is a very good diastolic flow, and diastolic flow is very good, then we can reassure. And this pattern is typically called as a Nandi pattern, the name given by Well sir. So whenever we see a Nandi pattern, it's reassuring to us. Normal RI is 0.5 to 0.7, and there are 2 indices. Sir also told this one is the RI and one is the PI. So PI is also very important, but in routine practice we are not that much used to PI, but PI is also very important. So resistive index RI is calculated as a peak systolic velocity minus end diastolic velocity upon peak systolic velocity, and PI is peak systolic velocity minus end diastolic velocity upon mean of velocity. So this is mean of all arterial velocity is generally considered here. So generally majority of the machines they give PI as well when we measure RI. So this is how. So this is a triphasic waveform. Here this is a peak systolic velocity is measured how, and this is the end diastolic velocity. But generally in intrarenal vessels, the end diastolic is the positive, so here is the end diastolic velocity. So actually what we are measuring in RI is actually proportion of the peak systolic velocity as compared to the end diastolic flow. So RI says that if RI is normal, that says that we have a good end diastolic perfusion. That means our intrarenal vasculature is a very low resistance. So the vasculature is normal and there is a low resistance flow is maintained. So most important thing is if you look at just end diastolic flow and it is good and it is more than 30% or 25%, then it is a good kidney and nothing to worry, and the RI is normal. So it's the same thing, but how we measure. So here is a peak systolic velocity and here is a, so maintain good end diastolic flow is the most important thing, and that suggests a normal Doppler. So I'm starting the first case. So a few cases, I have added few new cases, but few are classical cases, so which are attending second time the workshop, maybe same cases, because they are so classic that I wanted to demonstrate them. Here, a 50-year-old lady underwent live renal transplant with husband as a donor in last March, and I used thymo as an induction 1.7 because HLMH was 0/6 and standard triple immunosuppression was given. CDC and cross-match and DSA were negative pre-transplant. Transplant surgery was uneventful. There was good clearance and creatine was 0.8 on day 2 and it came to 0.6 on day 7. So everything was going okay, but she had some weight gain despite normal creatine. And this is a scan at day 5 post-transplant. There is absolutely normal Doppler with RI of 0.6. So this is a post-transplant day 5 with absolutely normal Doppler. So what happened on day 8, her urine output was slightly decreased and she was gaining the weight. But urine output was 3 liter, but I was not happy. Her creatine was still 0.8 on day 9, but urine started decreasing and I was worried, and take level was also optimum. It was 8.6, slightly on the lower side. So bedside Doppler I did, and what we found that the RI significantly increased, and it's not a typically broken horn appearance, but definitely the end diastolic flow is significantly reduced. So this is the intrarenal, and if you look at the anastomosis also, the RI is going up to 0.88 and there is a very less end diastolic flow. So now I was significantly worried, and on the same day we did biopsy. So POCUS made me to go for early biopsy. So we were not so late. We did biopsy on 0.8 creatinine, and despite that, to my surprise, it was a diffuse cortical necrosis in the biopsy with strong C4D positivity. Basically, it was a very severe ABMR. So with early POCUS Doppler, I had a very low threshold for biopsy, and the severe rejection I can treat. So we are treated with Plex and Solumetrol, and I also optimize MMF and CNI dose. So even after 5 plasma exchange, she was anuric, she was dialysis dependent. Before proceeding further, after 5 sessions of plasma exchange, I did repeat biopsy, and on repeat biopsy found that there is no cortical necrosis. Now there is only ATN. Still C4D was positive and evidence of ABMR was there, but it was improving. So with 5 plasma exchange, I found that there is some viability, and now I can be more aggressive. So we give further thymoglobulin, and thymoglobulin was given because we had initially given a lesser dose of 1.7. In the view of rejection, we have given additional dose, and further 4 Plex was done with IVIG. So it took almost 1 month to recover this graft, and finally she started making urine. She became off dialysis, and we continue to monitor her with the Doppler to see whether any improvement or not. So at 35 days post transplant, this was a Doppler, and now you can see that there is an improvement in the diastolic flow and diastolic flow, and RI came to 0.75. So now this graft, no, it's not absolutely normal, but it's started improving as compared to the previous one. So this is how a serial Dopplers can help us. So this is the scenario before rejection when there was absolutely normal Doppler pattern. This is a broken horn appearance with severe rejection, and this is how it looked in the recovery. So whenever there is a rejection, if you look at the basic grayscale or B mode, so generally there may be loss of CM differentiation with the severe rejection because of the edema in the medulla. So medulla becomes even hyperechoic and edematous. So there may be loss of CM differentiation, and swollen kidney can be seen during the acute rejection in grayscale. So, and already I mentioned that in color Doppler, what we see is either reduced end diastolic flow or absent diastolic flow, or many times, what is the most characteristic sign in severe rejection, there will be reversal of diastolic flow can be seen. That is also called as diastolic notch. So here you can see in this figure, there is a diastolic flow is totally reversed. So this can be a very short sign. This cannot be ATN. Such a reverse diastolic flow is seen with severe rejection mainly. Again, increased RI can also be seen in the ATN. So it's not always like that that it's seen in, it's very typical of rejection. But it's overall clinical scenario, it's overall clinical correlation that guides it whether it's a rejection or definitely biopsy is will be the definitely answer. Here the second case, here this is a recent one. Here a 40-year-old male patient underwent live donor kidney transplant with auntie, actually mommy as a relation. So it was ABO compatible transplant, and 0/6 full mismatch is there. Induction was thymoglobulin and standard triple drugs were given. Surgery was good, output was good, and baseline Doppler was done on the same day, which was normal, but showing some perigraft collection, which was not significant, around 20 to 30 cc. It was extra capsular collection. But from the start, there was some hematuria was there. Many times we see post-transplant hematuria, and generally it subsides in 2 to 3 days. On a very next day, on the post-op day 1 only, his urine output started decreasing. So definitely the first thing any nephrologist will do is a bedside Doppler. So I did the same thing. So what I found that to my surprise, there is a very less diastolic flow, and RI was significantly increased. Intrarenal is 0.88, and main renal artery, you can see velocity is also increased, and velocity is 159, and RI is increased to 0.92. So I was worried now. But if you see carefully, there is something here. So grayscale is also as important as Doppler. So with this, first thing come in mind is a rejection, because it's a poorly matched kidney, though thymo was given. But generally what we suspect is a rejection. But if you see the B mode carefully, there is a collection here. So this is it's not a very huge collection, but the important thing is this is a subcapsular hematoma. So generally, if extracapsular hematoma are crescentic or irregular shaped hematomas are there, but subcapsular maybe have such a typical case, typical look, and they are more easily found on the transverse section of kidney. So here I was not able to appreciate it very well, but this is a transverse section where it's clearly seen, and it was indenting upper and mid pole. So the volume of this hematoma was around 20 to 30 cc only, but it was abetting the kidney, and that resulted into the decreased urine output. And subcapsular space is very small, and even a small hematoma can raise significant pressure over the kidney, or it can cause page kidney. So urgent re-exploration was planned, and the subcapsular hematoma was drained with a small incision. There was a gush of flow. I was there in the OT, and within a few seconds the kidney became more turgid. Kidney was slightly flaccid because of the hematoma, and within a small incision it becomes turgid, urine output immediately improved, and intra-op only we checked with the Doppler whether the perfusion and RI is improved or not. So Doppler is a very dynamic investigation. So within a few minutes, you can see there is a this is a Doppler same day before surgery. This is intraoperative Doppler, and almost normalization of the end diastolic flow. The output was very good. So the subcapsular hematoma, even with a small volume, can cause such change. POCUS helped to identify it early and treat it early. And this patient had almost a normal outcome, and on the day 5 he has a normal creatinine and discharged well. So generally, surgeons don't miss this subcapsular hematoma. It is easily identifiable, but many times because of fat, they can be missed. So this is important. Generally, if the collection is extracapsular, even a large collections are not a problem. In our setup, we don't keep a drain after transplant. We generally keep degestant, but we don't keep drain nowadays. And generally, the hematoma is not a problem in our scenario. Generally, this subcapsular hematoma can occur because of donor nephrectomy. There might be some injury or during the handling of kidney, there is happened. So this is how Doppler can help us, and our worry of rejection was vanished, and we can easily manage. Even the surgery was not very big. It was small incision, and just within 10 minutes, we closed the wound. Now moving toward the third case, this is a very unique, and it was very challenging for me. Here again a young patient, 42-year male, and ABO incompatible transplant with wife as a donor. The titer was 1:32, and so he required only 2 sessions of Plex with Ritux before transplant. But he had pre-transplant evaluation, he had low C3, and so I did genetic testing because we are not sure whether he had about the basic disease, native kidney disease. So genetic testing showed that complement factor HR3, CFHR3 and 5 duplications in the workup. So we were slightly worried about that he might develop TMA post-transplant, and we counseled them, but there were no any alternative, and patient was not doing well on hemodialysis. So waiting on a cadaver transplant was not a very good option, and donor was wife. So spousal donor, we explained some with TMA. I also discussed this patient before going for transplant with many experts in transplant, but duplications are very common, and it's not an absolute contraindication, so we proceeded with the transplant. But in transplant this happens because we are expecting another complication and something another happens during the surgery. So what happened intraoperatively after clamp release, the kidney remained flaccid, and immediately we did the POCUS, and there was no flow in the graft. This is a nightmare for any nephrologist or transplant surgeon. So it's basically transplant renal artery thrombosis. So no flow in the graft, and only this is external iliac artery we can see, but there is no flow in graft, and graft was flaccid. So urgently the anastomosis initially was done with the external iliac artery, and the anastomosis was removed, and what they found it was a dissection of the external iliac intima. So intimal dissection was there. The reason we don't know, because this patient was 42, there was no atherosclerosis, there were no calcification in his arteries. So our surgeons told that it's a bad clamp. So when surgeons don't find anything, they say bad clamp. But it may be a possible reason. But what we did, because it was an emergency, so immediately first what we did, they removed the arterial anastomosis with the external iliac artery. We in situ reperfuse the kidney. What we do, we don't remove the venous anastomosis. We generally make a small rent on the venous side, and we perfuse in situ arterial, and we put a perfusion cannula. And after that, internal iliac artery anastomosis end-to-end done. This anastomosis was good, and after clamp release, the kidney became turgid and urine started, and now we were slightly relaxed. Now everything is okay. But this was not the end of the story. After that, this is a repeat intra-Doppler. The kidney was very good perfusion, and we were relaxed now. But our surgeons repaired the internal dissection and closed the external iliac. and the patient was shifted to room. Generally, our surgeon used to examine femoral pulses after every transplant. If femoral pulses are good, so generally there is no issue in external iliac. But soon after shifting to the ICU, patient started having some pain in his right leg, and right leg was slightly numb and cold. So it was not good, and femoral pulse was not palpable. So immediately we did POCUS Doppler at bedside in the femoral and popliteal artery, and what we saw, there is some flow was there, but it was a reduced flow, and you can see it's like a venous pattern, like it's like a continuous flow. So continuous flow in a femoral artery is not normal. It should be triphasic. So this was abnormal flow. So it was right external iliac artery dissection followed by thrombosis, and which is leading to limb ischemia. So we solved one problem, but we'll end up with another problem. Patient already had a surgical insult because of complication. He was making good urine, but now we have to handle this external iliac artery thrombosis. So urgent CT angio was done, and which showed complete external iliac cutoff. You can see in the here. Graft is well perfused through the internal iliac artery, but this external iliac is completely. But still there is a flow in the femoral through the collaterals. But patient was developing pain and coldness in the right limb. So ischemia is very dangerous because it can lead to dangerous hyperkalemia, AKI, and we can lose limb if anything goes wrong. So we involved our CVTS surgeon, and he decided to go for either aortofemoral or femoral graft. So aortofemoral is a big surgery because it requires to open the peritoneum, but femoral even doesn't require to open our transplant kidney. So we decided to go for femoral PTFE graft. And he did it very well, and without disturbing the kidney, we were able to do this. Because doing aortofemoral, there are chances that it might compromise internal iliac flow to the transplant kidney as well. And we were able to save the limb as well as the patient both. And now this patient has almost 2.5 years to the transplant. It's ABO incompatible, had CFHR related problems, but he fortunately never developed TMA. So POCUS helped to diagnose the problem early, also helped to manage and diagnose the external iliac thrombosis early and reduce flow in the femoral. So it can become a part of day-to-day practice. And another thing, genetic duplications in CFHR are more common. So they are not absolute contraindication to transplant. In case-to-case base, we have to select the patients carefully. External iliac artery dissection is a rare surgical complication, but it's a serious complication. So femoral graft can be a salvage option. Many colleagues suggested me that why during the surgery we didn't put a graft. But what happens whenever there is a dissection, we don't know the extent of the dissection. And what was happening, it was extending downward. So we were not sure about the actual distal extent of the problem. So that's why we planned for a femoral graft. And intraoperatively, actually, we were not sure that there is a thrombosis. So vascular complications are the most dreaded complications in any transplant. So renal vein thrombosis and renal arterial thrombosis, in which it's very difficult to salvage the kidney. So renal vein thrombosis, they can be salvaged only, like as sir said, this can be reversed only if we are able to identify within 30 minutes. Otherwise, we will lose these grafts. So this is also a surgical emergency, and generally the reason may be external compression by either a collection or kinking or a technical problem during the surgery. With renal vein thrombosis, generally kidney gets swollen and enlarged, and there is absent flow in the vein, and there is typically this reversal of the diastolic flow can be seen on the Doppler. In arterial Doppler, you will see there is a reversal of the diastolic flow. So this is a typical sign, or you can say W-shaped flow we can see in renal vein thrombosis. Renal artery thrombosis we already seen. It's also very rare but grave complication. There is no flow in the graft. Then renal artery stenosis, we already have some discussion, and already we have a separate session for this. But generally in renal artery stenosis, PSV is very high. Generally books and theory says that PSV more than 2 meters per second or 200 centimeters per second is considered as a high, and we have to suspect renal artery stenosis. And another signs are very also important, not only the PSV. As sir said that even a PSV more than 1.5, and you are if seeing this color aliasing sign or mosaic, then also we have to suspect that renal artery stenosis. Another important signs in intrarenal beds, this typical tardus parvus pattern or reduced PSV and reduced RI. So already we have a separate session, so I'm not going into detail about you can see here the velocity is very high. It's almost 4.9. So it's almost 5 meter per second, so very high. For this, many times we have to lower down the baseline in the machine, as well as many times we have to adjust the velocities of the machine as well, if very high velocities are there. So this is how the mosaic and even narrowing is also seen, and the turbulence in the renal artery stenosis is seen. This is a typical tardus pattern. Sir also showed in his recent patient as well, this flow pattern was seen in renal arteries. So moving towards the next case. Here a 42-year-old male recipient underwent transplant with wife as a donor. This was ABO compatible transplant. Transplant was uneventful and had a creatinine of 1 on day 5. So generally on 7th day we remove the Foley's catheter, and on the 10th post-transplant day generally we remove the DJ stent. So similarly it was done, and immediately after the stent removal patient started having fever. So there was a clear diagnosis. This is iatrogenic infection to the transplant kidney, and we sent the cultures and we upgraded the antibiotics. But he was not improving, and he was persistently having high-grade fever. So we did ask our radiologist to do the ultrasound and Doppler, and he said there is a pilates, and otherwise Doppler is normal. So we continue the antibiotics, and we reduce the immunosuppression. But his creatine was rising rapidly. This is a post-transplant day 10 when his creatine was 1, and day 12 1.8. Almost it was doubling in a day. So in just 5 days, creatine reached up to 5.5. Though he was able to make 3 liters of urine, but he was not improving. He's having persistent fever. So initial Doppler was suggesting only pilates and normal Doppler. So I started to follow this patient daily with the ultrasound and POCUS. So what I found, there is some hydronephrosis is there along with the pilates on day 13th. So many times what happens after Foley's catheter removal, in early days there may be some reflux, and many patients have a high pressure voiding. So we reinserted Foley's catheter, and again after 2 days I repeated the POCUS. So patient was not improving. Creatine was 5.5, high grade fever persistent, and there is a slight increase in hydronephrosis, and even after Foley's catheter the HN was not improving. So definitely the now diagnosis, there is some ureteric obstruction is there. So we consulted our surgeons and asked them to do again the re-degestanting. Re-degestanting in a transplant kidney is always difficult because they are not easily, they cannot find the orifice of the anastomosis. So many times they prefer PCN over doing the degestanting. But fortunately, our surgeons were able to insert a degestant in the transplant kidney, and cultures were sterile, but still persistent fever. We upgraded antibiotic. So at least after stenting, his infection improved, fever subsided, and patient came better. So it's possibly because of the infection and there is some ureteric obstruction, there was graft dysfunction. But actually, so POCUS helped us. But story didn't ended here. Actually, this patient's graft function didn't improve. He required dialysis. We did biopsy. Biopsy was suggestive of acute interstitial nephritis. We stopped his Bactrim, and still was not improving. So for 1 month he was on dialysis. There was no signs of rejection. Cultures became sterile even after 14 days of injectable antibiotics, aztreonam and ceftazidime-avibactam. But he was not improving. Then I had to switch over from tacrolimus to everolimus, and surprisingly patient improved, and his creatine came to normal. He was discharged. We gave alpha blockers. We removed the stent. We removed the catheter. And his patient is almost now 2.5 years post-transplant now, and still his creatine is normal. So the reason of graft dysfunction most probably was ATN with some interstitial nephritis, along with the pyelonephritis. So the stent helped to recover the pyelonephritis definitely, but the bigger picture was also there. So now he's fine. So ureteral obstructions and hydronephrosis can occur 3 to 6% of grafts, and majority of cases are because of the obstruction at view junction. So either it's a technical problem, or lymphocele or urinomas may be the reason, hematomas or abscesses. If the obstructive hydronephrosis, generally RI is elevated, but in our patient the RI was normal. So it's not always that in case of ATN or in this case is always not there RI is elevated. So RI was normal in our patient, but generally obstructive hydronephrosis, it's elevated. Non-obstructive dilatation are also very common, because many times though they use anti-reflux techniques, but still there is some view reflux is there in transplant kidney. So many times because of that also, initial ureteric edema is also very common post surgery, that may be so mild hydronephrosis or mild dilatation of the renal pelvis in the transplant kidney. And many times even with a severe rejection, you can see some fullness in the renal pelvis. So acute cases are generally post-surgical or surgical complications, but whenever there is a chronic ureteric obstruction, we also have to rule out other causes like BKV nephropathy. So I'm moving towards the last two cases. So in this patient, this is not a very uncommon scenario. A 50-year-old patient underwent live transplant with wife as a donor. Despite spousal donor, there was a 4/10 match, thymo and triple immunosuppression was given. So he was everything was okay, and he was discharged. But in follow-up, when he came, his creatinine was increased to 2.2, and there were some pus cells in his urine examination. So culture stent, and I did POCUS, why his creatinine is, I was suspecting is there any pyelonephritis or not. But transplant kidney was absolutely okay. What I found is there is some collection which is anterior to the graft, and Doppler is absolutely normal. So looking at the Doppler, I was not worried about the kidney. Most probably at this location, it should be lymphocele. So we aspirated the fluid, and this was the exact volume. It was around 250 cc. Generally, graft dysfunction because of lymphocele can only happen if it is compressing the graft or the ureter. So this was anterior to the kidney. So generally, chances of compression over ureter are less. So most probably first differential will be lymphocyte, second urinoma. Urinoma is not the proper location for the urinoma, but we did USG guided aspiration, and fluid creatinine was done, which was almost normal, equal to the serum, that was 1.9. So it's a lymphocele. So we drained it initially, and we followed with the POCUS. The volume was reduced, and in follow-up the patient improved. So though it was not a very large lymphocele, but after the draining the lymphocele, his graft function was improved. So whenever we see collections, so if it is organized collections or septations, generally it's a hematoma. If it is a pure anechoic collection, either it's a urinoma or lymphocele. How we differentiate? So urinomas are generally near the ureter. If we aspirate it, the fluid creatinine will be high. Even MEG3 scan can help us, or contrast study can also help us, but generally we try to avoid the contrast. And majority cases, by POCUS only, we can differentiate whether it is a urinoma or lymphocele. As I already mentioned, in lymphocele, it can be present in any location. Generally, fluid creatinine are same to the serum, and MEG3 scans are negative. So the USG guided aspiration can help us. MEG3 scan we can do, or many times contrast study can also be done before planning a reimplantation or definitive surgery. Here you can see there is a contrast leakage near the ureteric anastomosis with the bladder, and here there is an anechoic small collection near the ureter. So lymphocytes are also very common, and generally they are seen within the first year of transplant, and 5 to 15% of cases we can see lymphocyte. And majority of cases generally we wait and watch, but if large collections and if they are associated with the graft dysfunction, we may need to aspirate it. This is the last case. This is also not a very rare scenario. A young lady underwent transplant, husband is a donor, good recovery and discharge, and in a smooth way. But again, in the follow-up, I found that there was some weight gain, and her creatinine was rising slowly. So, transplant Doppler by radiologist was almost normal at the time of discharge. So we thought is generally husband to wife, I think, is the most worrisome pair in a transplant. They are more, because females are more immunogenic, they have more exposure to antigens, and whenever the husband is a donor, because of previous pregnancies or abortions, they are already sensitized. So even though I have seen that the pre-transplant workup is negative, these patients, there are more chances of rejection. So I was worried, is there any rejection or not? But everything was okay. But what I found that she had a significant post-void urine. So many times POCUS helps to identify such a simple problems to very complex problems we discussed previously. So the treatment is simple. We again put a catheter. We gave alpha blocker for a few times, and her graft function was absolutely normal. And we were again able to remove the catheter. And again, it's very important that not all pelvis collection is a bladder, because many times this is a pelvic ascites. So we have to see in both the view is very important to label it as a full bladder, because many times this is measured by anyone as a full bladder. So biopsy was postponed definitely, and it was treated. So many times what happens, our patients are on dialysis for a long time, they are anuric, so mild bladder dysfunctions are common after transplant. But yes, if patient have persistent post-void urine, then we need to rule out is there any bladder neck stenosis or is there or not, or is there any bladder dysfunction or detrusor dysfunction is there or not. But in this patient with simple alpha blockers, for few months the problem was solved, and further management was not required.
So sorry to interrupt, but we already running short of time.
Yes, so I've completed. So POCUS can help to identify simple to complex problems, and many times it's just a delight to watch your dual kidney graft doing very well. It's like they are giving high five to each other. Thank you.